on this episode of A Tale of Two Hygienists.
I keep telling dentists, if you spent a day in a hygiene program and watched this, not only the acumen, but the level of stress, if you saw how hygiene students strive to be the very best they can be every day, you'd feel confident having them there all the time.
So how can we help this child grow to their full potential? Because if they are already underdeveloped at 2 or 3 years old, it doesn't matter when they get to 12, 16, or 18, they're still going to be underdeveloped for that age.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists podcast, episode number 510. I'm your host, Andrew Johnston, and thank you so much for being with us today. I've been feeling very nostalgic lately, and so sometimes when I feel that way, I go back and listen to some of our past episodes, some with our favorite guests on there, and I just try and listen for, because when I'm interviewing people, I'm not always listening to their words in a way of learning. A lot of times I'm listening to them just as normal conversation. And so I like to go back and try and find the little Easter eggs that I might have missed. And in doing so this week, there were a couple episodes that I wanted to kind of maybe pick some pieces out of and reshare them with you, because I know a lot of you are the faithful listeners, and I appreciate that. But there's also a lot of new listeners that haven't either been able to go back into the library from years and years ago and listen to them, or for whatever reason. So I put together a few of these things that just felt like good reminders. And it's interesting, though, because sometimes, advice, you pick up a book, right? A book that was written 10 or 15 years ago, and you pick it up and you're like, man, this is such good advice and still applicable for today. That's kind of how I felt as we were going over this. And so even though these episodes aired, I believe, a couple of years ago, a lot of the advice, still kind of stands the test of the 2 years' time, I guess. So in today's episode, we'll be hearing from Tom Viola. Misty Mattingly was kind enough to co-host with me on that episode. We talk about local anesthesia, not so much about like the mechanics of it, but kind of the qualifications of the dental hygienist, why dental hygienists should be allowed to administer local anesthesia pretty much in every state, and kind of what requirements they went through in Georgia a few years back when they got that passed. And then the second half is with Renata Nehme, and she talks about palatal expansion as an adult. And it's one of those episodes that's really fascinating for me, because you hear about palatal expansion and early interventions and things with children, but you don't really hear them with adults. And there's kind of some controversial, should we or should we not be expanding our palates as adults? And so I like to listen to her episode. It was really nice. She's really smart. All of these people, Misty, Tom, Renata, they all have their own platforms. And so I really encourage you, go to the show notes. I'll link back to all of their stuff with what they're currently doing. Make sure you follow them, pick their brains, send them an email. They're incredibly smart people. And I just feel very lucky that they took the time to spend with us on the show. So fascinating stories, experiences that, maybe, again, if you've heard it before, then you'll probably still enjoy it again. Thanks again for being here. We'll talk to you soon.
A tale of two hygienists.
Makes sense.
It sure does. I was involved in the rollout of anesthesia for hygienists in New Jersey and Pennsylvania, and I did the pharmacology portion of the training in those two states for, thousands of hygienists. And even though I wasn't a big part of the clinical apparatus that brought the hygienist in and had them do the actual injections, just teaching them the theory, the one thing that I noticed was missing was it was hygienists teaching hygienists, which was amazing, and I loved it, but there were no doctors there.
Right.
Because I think if they were there and had seen the stringent process, the requirements, that the way the faculty worked so well and so hard to make sure that it was the very best technique, I think that would have built a lot more confidence in the docs, and they would have said, hey, wow, I feel confident having my hygienist undergo this training because I now have confidence in him or her being able to perform well in my operatory.
Yeah.
And I think that's because a lot of dentists don't understand what the training is all about with hygiene, because a lot of them are not hygienists. They didn't undergo hygiene training. But I always give them that perspective because I'm the outsider looking in as the pharmacist. So I watch how the training goes, and I keep telling dentists, if you spent a day in a hygiene program and watched not only the acumen, but the level of stress, if you saw how hygiene students strive to be the very best they can be every day, you'd feel confident in having them there all the time. And that's where supervision comes in. Some states allow the doc not to be there and have the hygienists practice under general supervision. If I saw my hygienist undergoing that kind of training, I'd be 100% confident knowing that they can handle things without my presence there. Again, if the state allows it. Now, the opposite of that is some docs don't know and will say, well, since I don't know, I'm going to assume it's the worst. And I get that, because I think anybody would if they're not familiar. And so I think that's education. Well, name me one other profession other than nursing where you come in basically with absolutely no skills in dentistry whatsoever. You're a complete novice, but yet and somehow in 2 years you have to pick up an instrument that you've never held in your hand before and be able to work on a live patient with that instrument and perform so well that you can pass a peer-reviewed exam at the end of those 2 years, having never had it in your hand to begin with 2 years ago. And if that's not enough, then also understand all of the academics, the pharmacology, and all those other courses you have to take. Tell me what other profession gets that all done in 2 years. First thing I do in my course is when I start teaching pharmacology, because it's one of the more difficult courses, and I say, okay, how many of you have cried?
Oh,
In
we've
this
all.
program, and they all raise their hand like, I've cried at least once. Yeah, I'm like, it's only September. You've cried already? You're like,
And you're like, if you haven't yet, I'm going to make you cry. No, just kidding.
wait till I tell you have to memorize the top 100 drugs. You're not going to be so happy about that. You may cry. But that's the point. If anybody knew what hygienists go through, that's why I always say that same thing. Give me another profession that could do that level of stress and apply that to a person who, let's face it, isn't ready for it. You really have nothing to guide you. You have no way of knowing what hygiene school is going to be like until you're already thrust into it.
Oh,
The interesting thing about that, though, is like all of these, I would say movements or whatever of let's make hygiene school easier. Let's make, the exams easier. Let's do all of these things really frustrates me because to what you're doing in Georgia, the 80%, which is 5% higher than what the standard is, I like that it's hard to be a hygienist. I like that it's hard to get through. I like that not everybody passes. When you have your student group and then you're between 1 and maybe like 3 years, out of school, that little 5-year span, all of them probably have a similar opinion. Like, that was unnecessarily hard. We shouldn't have had to do that, blah,
Agreed.
blah, blah. But now you look at us, and we're like, no, you're our colleague. We need you to be coming out of school prepared.
Top shelf.
We are going
Top
to
shelf.
be not fighting with the doctors, but some of the dental boards don't play nice. You guys sound like you just play nice in Georgia, at least. A lot of other ones don't. Hygienists, doctors are not on the same page. But if we can go back and say, no, look how difficult this was. We have objective evidence to say we are qualified. But if we start dumbing that down, do you feel qualified as being a business person right out of school? And almost all of them say no. 5 years out, they still don't. And even 20 years out, a lot of doctors are like, I'm not really good at the business part of it. I have my CPA do it. My attorney does their stuff. My malpractice people do this stuff. I have other people do it for me. Who of them are really qualified to educate on hygiene? Right? Like,
True. Yes.
they
good
have
point.
a small amount of perio in their curricula, which is fine.
Okay.
They're diagnostic, which is why AI needs to come in and help, like with Alabama too. But we just had an episode where it's like, you have a third opinion. You have a hygienist opinion, you have a doctor's diagnosis, and then you have like software that can help you read all of this information, right, and make sure that we're doing the right thing. But like, a lot of them aren't really qualified to be educators. So that whole preceptorship thing doesn't really make a lot of sense for that scope of practice, unless you have such a narrow scope of practice where it is a two-scraper. It is this is literally all
but
you're
I
doing.
think
I'm
that's
checking
what they
calculus
use them
check.
for in Alabama. I mean, come
Probably.
on. And it's Alabama.
But how terrible is that, though, when we want to have reciprocity? They're going to all hate you. It's Misty.Mattingly at... No, I'm just kidding. But we want
That's
reciprocity.
okay. Me and my family, we could probably fit in Alabama just fine. I'm a country
accent.
bumpkin with the accent. I fit in just fine.
We want reciprocity, right?
Yeah.
But we're not all being taught the same thing, to your point. We're not holding everyone to the same thing. And so now that you guys have such a high standard in Georgia with local anesthesia, you want someone from preceptorship to have reciprocity in Georgia? That doesn't make sense to me.
Training.
Are you concerned that you're going to get backlash, that you guys are over-training, over-preparing, asking too much?
Yeah, I I think we already are getting that.
Good. But rightfully so.
Understandable.
and
We went through the same thing in Pennsylvania and New Jersey as well. Yeah.
Yeah. I think how many
Yeah.
hours do you guys require there?
So I'm trying to remember the exact number because it's off the
I
top
have
of
it
my
on
head.
this computer.
Yep. So you probably would know better than me because I only taught the pharmacology portion, but I still had to do 16 hours of pharm
Yeah.
in that initial training program. That was a whole weekend just of pharmacology, just going over health histories, going over medications, going over anesthesia. And I didn't touch on accuracy, I didn't touch on technique. It was just the agents themselves.
Right.
And then they underwent another full weekend of just clinical, learning injection techniques, injecting each other. It's grueling. Some of the programs actually spread it out over more weekends, 2 or 3 weekends, because it's just too much
Right.
to be able to learn at once.
Ours was in our curriculum in school. Like that was part of our courses.
exactly.
And so it was a little bit easier. We didn't have to like cram it in on the weekends.
Well, and I think
Exactly.
that's the best way to do it,
It should
right?
be,
I think
yeah.
that's really the best way, and our schools will get there in our state. Right now, they're not. And so she
Agreed.
was like, I really want hygienists to be able to do it in my practice. And I was like, oh, I love that.
Well, I will say that when it comes to workflow, it's outstanding because you really can have your staff now direct the hygienist and the dentist into the different operatories and follow a workflow that you normally wouldn't get because, as you said before, Andrew, it's stop and start. Doc comes in, gives you anesthesia, doc walks out, hygienist. But here's my problem. Some hygienists that I've spoken to said, I'd rather not anesthetize the doctor's patients. I like my patients, and I know them very well, and I will anesthetize them. But once you ask me to start anesthetizing the doctor's patients, I don't know that patient as well. I have to do more research into medical history to feel comfortable, and to be honest with you, I'd rather not. And I get that point of view
And
as
I
well.
get that
good
point of
point.
view
Yeah.
too. And I think it doesn't need to be for everybody.
Right.
I
Exactly.
think everybody needs to do whatever they're comfortable with.
But to your point, what is the definition of a hygiene patient? If I'm a doctor and I'm looking at this, well, okay, I'm going to have to pay. I'm going to make sure that my patients who need both services are going to see the hygienist first. They're going to get their anesthesia from the hygienist, and then that's one less person I have to anesthetize. So I see that working that way too. So, in my opinion, I think it's good that it's there. Good that there's some proviso for that. But I think that can easily be used to every practice's advantage. Like you said, it doesn't have to be everybody.
If someone wanted to reach out to you, how is the best way for them to reach out to you?
Well, website's the best, tomviola.com, or social media everywhere at Pharmacology Declassified.
Appreciate you, man. Thanks.
Thank you, Matt.
Renata, welcome to the episode.
Thank you so much for having me. Hello, everybody.
First of all, just a quick little synopsis of kind of your background in dentistry.
So I became a registered dental hygienist in 2010. I'm in Savannah, Georgia, and I worked for 3 different practices pretty much my whole career. 1 year in pediatrics, and then pretty much just for 1 other office after that. So I was there for close to 10 years. So I was just one of those hygienists that I didn't do just hygiene. I did all the photos for the practice. I built the website. I organized all the HIPAA stuff, all the paperwork. I did a little bit of everything.
Were you asked to do all of that, or did you just volunteer? You're like, I love this stuff so much.
The practice that I worked for the most, they had 2 chairs when I started. And when I left, they had 10. So I was in the process with them as they were growing. And I am very hands-on, and I do love doing stuff and helping. So it was a mutual agreement.
No, I love it. I love it. So one thing that you're experiencing right now is you are doing palatal expansion as an adult. What I would like to do is maybe start this back for a few of us. I didn't actually learn about palatal expansion until many years into my career, which I kind of felt bad about, but really, I don't think that that's all that abnormal. If you don't work in pediatrics, if you don't work in any sort of a surgical suite, you might not know that that's a thing that happens. So do you mind just kind of going through the process of like, why do people get, palatal expansion? Like, what are kind of the indications for it? And then like your experiences with it.
Of course, traditionally, we only recommend somebody going to see an orthodontist if they have malocclusion, so if they have crooked teeth. Or we all are familiar with a posterior crossbite, when the upper maxillary teeth are kind of inside of the lower maxillary or lower mandibular molars in the back. But many people don't get that fixed when they're young, And now that I've been doing myofunctional therapy for 8 years or so, there's just this whole new world out there of looking at jaw growth, craniofacial development. How big are your jaws actually supposed to be? As a myofunctional therapist, we work with muscles. So we're working with the tongue function, position. And one of the main things is, where is your tongue supposed to stay? It's supposed to stay suctioned in the roof of your mouth. But you have to have enough room up there. So that's where palatal expansion comes in. So we start measuring. There are some dentists coming out saying, what kind of measurements we should be looking for. But that's how I got introduced to it. When I was 14, I did have a palatal expander just because I thought that people had, braces talked funny, and I wanted to have a lisp. So I asked my mom, can you please take me to the orthodontist because I want to be cool? And I got there, but my teeth were straight. So she said, you don't need the braces, but would you, advise? I had no idea what it was. I did not understand exactly, but it made me talk funny. So I loved it.
Now, 14 is a little bit on the older side of getting this originally. When do they usually start looking for this in children?
So we can tell if a 2-year-old or a 3-year-old is going to need braces. Baby teeth are supposed to be like a picket fence, a tooth and a space, a tooth and a space. So we already know if they don't have any spaces on baby teeth, their jaws are already too small. There are many dentists out there right now, especially pediatric dentists, that are going into early intervention. So how can we help this child grow to their full potential? Because if they are already underdeveloped at 2 or 3 years old, it doesn't matter when they get to 12, 16, or 18, they're still going to be underdeveloped for that age. Mm-hmm. So there are things now that we can do. We can do some habit correctors. There are several different brands out there. Myofunctional therapy, of course, to correct the position of the tongue. Nasal breathing, those are going to help the jaws grow to its full potential. The pressure of the tongue on the palate actually drives the maxilla to grow forward and sideways. We call it transverse and AP. So there's a lot that we can do now in the beginning, but we always start with nasal hygiene. Another reason why all the jaws are shrinking, because people are mouth breathing way too much.
Mm-hmm. Yeah. So in your particular case, so you had it, but then it shrinks. Like you relapse. What happened there?
Yeah, that's the word, relapse. We all relapse. How many times have we seen patients that have had braces 2 or 3 times? Why? We never asked why. As a hygienist, and I was one of those inquisitive children, and I'm always still like this. I feel like that's why I'm in the position that I am right now. But I wanted to know why. Why are people relapsing? So it's because we're not addressing the muscle. And I like to compare it to, if you go to a chiropractor, they're working on the skeletal structure. So they kind of, twist and turn and move the skeletal structure to the correct position. But why do you have to go back week after week? Because the muscle is not being addressed. If there's muscle dysfunction, meaning one muscle is not moving how it's supposed to be moving, your body is very smart. It's going to engage incorrect muscles to perform that function. The same thing is happening to the head and neck. What are functions that you do with the head and neck? So breathing, chewing, swallowing, speaking. If you can't do those correctly, and we have to do them all day long, we all do them. But if you're not doing them correctly, the incorrect muscles are going to engage, and then you might have issues. You might have TMJ pain. You might have headaches, neck aches, and things of that nature.
Were you a little bit nervous about getting the screws put in your palate again?
Extremely. I am the worst dental patient. I do not like getting dental work done. And then whenever you know that you're going to get anesthesia on the roof of your mouth, we all know that's the worst place. Oh, yeah. So I was extremely nervous. And thankfully, I went to the best orthodontist in the country, Dr. Ilya Lipkin. He's in New Jersey. So I flew from Savannah to go see him. He's seen a few of my patients. But he does, I think it's the endo eyes. He uses that to freeze the area where the needle is going to go.
It's very smart.
Genius.
It's very smart.
Yeah, so I didn't feel not even the anesthesia.
Tell us more about the procedure that they did for you.
So this is called the MARPE. It is maxillary expansion. It's not necessarily surgical, because you don't have to be put to sleep. There are no cuts, but you are going through mucosa into bones. So it could be, seen as a surgical, depending on who you ask. But it's called the MARPI, and they do 4, 6, or 8 screws in your palate. And it's very interesting because, yes, they use it a drill, but they have to take impressions. You do a CBCT X-ray first, a 3D imaging, to look at the size of everything, look at the thickness of your bone. And now they're so advanced that they will send that scan to a company who will place the screws digitally into the places where you have the most bone, where it's going to, be smarter. Back in the days, there are still some dentists that do the MSC, maxillary expansion, surgical expansion, I think it was called. Anyways, but the MSC is just the name of a device. Now, MARPI, they're all of these types of expanders, but they can be customized now. And this is how they do it. They do the CBCT, send it to a company. The company designs the MARPI based on what you look like. And then the dentist, an orthodontist in the office, I was awake. There were children next to me in the other chair. And he places those screws in your palate, and you leave the office already with this device. And it does hook to your molars. So you have bands around your molars, which make you have an open bite. I think that was the worst thing that I was not expecting. All of a sudden, my teeth are only in contact in one place where that metal is. And thankfully, I went ahead and started Invisalign on the lower. So it gave that metal a little bit of a cushion. So it didn't bother me so much. But when I had to take my Invisalign out to eat, it was super difficult because you don't have full occlusion. So your teeth are not touching at all. So like you can't chew salad. There are certain things that I was swallowing everything whole.
I bet. So you go through this process. How many weeks or months are you doing this?
So I got this installed on May 11th. A week later, May 17th, I started the turns. And you're supposed to turn. There's also many different providers out there. They will tell you to turn 3 to 4 times a day. Others say once a day. And new research is going to come out in the next 5 years. And the research is saying turn slow. Because as a child, whenever you get an expander there, as a child, your suture is still very malleable. So they put a rapid palatal expander, RPE, in your palate, and you have to turn super fast. That's because if you don't do that, it's going to actually move the teeth instead of moving the bone, the suture, opening the suture in the middle of the maxilla. Whenever you're an adult and they put this appliance actually in your jawbone, it's in your palate, it's embedded in bone. So you don't have to move fast. You're not going to move teeth. So I think within the next 5 years, 1 turn a week will be enough. But then it makes the process so much longer. So I've been doing this since May. It's September now. I should have been done already turning, but I slowed down a bunch after I've been talking to so many professionals, and I learned this. We should be doing it a lot slower. But I think that I am done. I may turn 5 more times or not. I have to talk to my orthodontist. So the process now is Invisalign on the top, close the spaces. I'm not sure if they're going to have to do some composite to fill the empty areas. I think they usually do that behind the canine or behind the first premolar. And then, revisit what am I going to do after that? Are we going to do veneers or something like that, or just leave it alone?
So this is an audio podcast, so people can't see you, but you have obvious gaps now, which you didn't have before, right, in your anterior teeth. You also mentioned, though, that you've noticed some other kind of external facial changes. What were those?
Yes. Oh my gosh, my face looks so different now. So if you think about what the maxilla is a huge bone. It goes all the way underneath your eye socket, to the top of your mandible. It covers so much. Your nasal cavity is inside your maxilla. So every single time you're moving the maxilla, you're expanding the maxilla laterally. With the MARPI, it's also coming forward a little bit, maybe 2 millimeters or so. But it's moving everything else. So my cheekbones are so much higher. My upper lip looks beautiful. It literally looks like I got fillers. because since the maxilla came forward a little bit, it's supporting my lip a little bit more. So it kind of has everted my upper lip where it looks fuller. It looks beautiful. I love it. My nose is wider. My eyes are a little bit wider. It's very interesting if you look at my before and afters.
That is interesting. That's something that I never would have thought of in a million years. I mean, we do know, I think from past episodes that we talked about, like, the shape of your nose is going to kind of widen and drop down just a little bit, right? But the rest of like the cheekbones, all that stuff, you never really think about all this stuff. So Renata, you do a lot of things in dentistry. If someone wanted to reach out to you, if they wanted to follow you, learn more about myofunctional therapy, whatever, where can they reach out to you at?
Of course. So social media, I am all over social media all day long. I have 2 main Instagram accounts. One of them is Myo Moves, MYO Moves. That's my myofunctional therapy practice. I see all my patients online. And then I also have Airway Circle. We're on Facebook and Instagram. So if you'd like to learn more of how to become a myofunctional therapist, we have something called Myo University, where we offer some courses from beginning to end to get a dental hygienist from leaving the dental office, starting their myofunctional therapy career, all the way to how to start a business, and tons of support and an advanced course.
Thank you so much for all that you do, and thank you for being on the show.
Of course. Thank you for having me.
All right, listeners, that is our show for today. Thank you so much for joining us. Be sure to reach out to all of our guests. Give us a follow on social media. Make sure you hit that subscribe button. And if you have a minute, head over to our website and sign up for our newsletter. All right, we'll see you on the next one. This has been a production of Endeavor Business Media, a division of Endeavor B2B.